I'll turn to our first speaker, who you see here on the screen, Dr. Patel, who is Chief Health Officer with Florida Community Health Center. Dr. Patel.
Hey, everyone. Thanks so much for that introduction, Cheryl, and good afternoon. I'm Dr. Patel. I'm the Co-Chief Medical Officer at Florida Community Health Centers. We serve communities across five counties in South Florida and the Treasure Coast, as well as Lake Okeechobee. We operate 14 centers caring for roughly 50,000 patients for their primary care needs. At our organization, the Target BP initiative has really become a cornerstone of how we think about quality improvement for hypertension management. So wanted to share 3 ways we're currently leveraging it and one initiative that's on its way. So the first is around standardizing accurate blood pressure management. We've standardized it across our 14 centers, emphasizing calm, repeated readings and proper patient positioning. We usually get the blood pressure measurement at the end of our vitals. Just makes it a little bit more calmer, makes it calmer for our patients, and helps with getting that accurate reading when patients are a little nervous being at the doctor's office. 2, we have embedded care management into hypertension care. Our care managers partner closely with our clinicians to support follow-up, provide patient education, track treatment adherence, and even take a look at medication escalation. If they notice a patient has had blood pressure readings that have been really, really high and notice the patient is only on one medication, they'll gently nudge or suggest to the clinician to consider escalating the therapy. 3, we use data for continuous improvement. We've leveraged real-time quality dashboards to identify trends at both the center and clinician level. And these data points help us target coaching, celebrate improvement, and really drive accountability through timely feedback loops. And we'll talk more about that in the next slide. But the last thing to mention here is in process. So we're constantly adding new ways of thinking about hypertension management and treatment. What we're currently working on is developing a treatment and escalation algorithm to help clinicians think about hypertension care in a more standardized way, how to utilize care management in that process, and then when to refer out to a specialist when things are a little further down the line. The goal is really to reduce variability in hypertension management and improve overall control system-wide. So alongside that Target BP work, we've built out a set of clinical quality measure scorecards to keep performance visible and really actionable. So we take an iterative approach to this. You'll see 2 versions of our clinician scorecard here. The first one we created just a month ago. We updated our dashboards to better visualize which clinicians were meeting or not meeting their UDS hypertension goals, as you can see highlighted in red there. And this was just the first way of thinking about, when we look at our clinicians, who are the outliers and how can we better support them in taking care of patients. This past month, with the help of our wonderful clinical quality improvement supervisor, Verna Mackey, who's on this call as well, we were able to create another dashboard that looks at these UDS measures in a composite score and looks at it from an NQL heart health metric measurement. And that gives us a better idea of, how are folks performing overall. And we can take a look at it by center, we can take a look at it by clinician. And that really gives us more of a holistic picture of how we're taking care of our patients and if there's anything we could do to do it better. So just closing thoughts, my biggest encouragement to everyone is to keep quality work iterative. What works today may not work tomorrow, and that's all right. The key is to constantly refine, remeasure, re-engage teams in the process of improvement with our different versions of our quality scorecard. Similarly, we're constantly thinking about how to add new ways of improving our hypertension management, our diabetes management, and so continue with that way of thinking. Don't consider things as set in stone, even something as simple as a scorecard. So thanks again for the opportunity to share my experience.
But I want to ask our health center representatives on the call in terms of how they manage, thinking through that prescribing of the single pill versus the combo pill with the cost considerations, patient needs? How are you navigating that conversation with your patients and their insurance and the cost of it as well?
Using our pharmacists is something we do at Florida Community Health Centers. We're just starting to create like an algorithm for our hypertension management, but to bring some insight from our diabetes management, what we have done is we've created like a formulary or an algorithm for our patients who are insured, and then an algorithm or formulary for our patients who are uninsured, and then looking at the general cost of those medications for our patients. And so clinicians can then utilize these when they're seeing the patient to see, what would the general cost be for our patients as they prescribe XYZ medication. And it's based on national guidelines that ADA and others have produced, but it's also practical. Some things are covered, some things are hard to get, some medications that you need a prior auth. And so taking those things into account to improve access to these medications while also at the end of the day thinking about what's truly available to our patients.